6:48. Let's go to the K-Wave News Zoom room. Dr. Felix Cabrera from the Physicians Advisory Group is sitting in a stairway somewhere. Good morning, Doc.
Good morning. I
Uh,
was
we're,
just trying to match your guys' backdrop.
Hey.
I know that's pretty cool. Well, thanks for joining us, Doc. And we'll just, I guess, start with you had another big press conference to close out the week where you talked about the anticipated spike in hospitalizations, which we have seen. I mean, it's been gradually happening over the last couple weeks. So if you could, that projection was a few days ago. You still standing by that data?
Yeah, because basically we had two different ways of projecting or doing a trajectory for the hospitalizations. One was more of an aggressive one. One was more conservative. We've been trending, very early on. Unfortunately, we were trending above the aggressive one. But as of right now, we're not increasing at the same rate anymore, which is a big relief. Relatively speaking. But it's still pretty high, and right now we're kind of trending in between those two different lines. Basically, there was a red line and there was a green line, and so we're kind of along the middle of that.
I wanted to follow up on the SIF, the SNU, because they're trying to open that to deal with the overflow of patients. Do you know if it was opened yesterday or not?
So my understanding was that they were getting the chillers up, but what I'm having trouble wrapping my mind around is that just having the facility ready and having the staffing ready for it are two completely different things.
Right.
And there was a lot of talk about it just being, we should be ready to take patients, by this evening, or along those lines. And so to me, I haven't heard as much of the information about the staffing. So I'm not going to come. Maybe there is that they're ready to split up staffing in a way, but I don't have that complete understanding right now. All I know is that I'm just extremely grateful to the Guam National Guard and the state surgeon cell for really pushing through and getting this done. They're basically the baton was basically handed to them to get this thing out of because it was stuck in procurement for so long, and to kind of move things along and get it going. I think was a tremendous accomplishment to do it in such a short time frame. We've been trying to work on this. I know GMH have been trying to work on this for several months, especially during the lull we had in cases. But it proved that we definitely did need, and that this was much higher of a priority than we initially had thought it would be.
Yeah, I think that's interesting because, I mean, again, it comes down to the staff. But as we anticipate the opening, well, we have been anticipating the opening of this for a while now. We're also having conversations with Lillian where she's saying, hey, we're reaching out to DOE. Hey, we're asking the military. So, but I'm not sure, Dr. Cabrera, if these asks that we're making for the additional staff would just be to staff like the hospital, or would it be to staff the hospital and the SNF and the ISO facilities or wherever else we need the bodies, because we definitely need the bodies.
Well, according to
the
Lily,
staffing is primarily for the hospital, for sure.
Okay.
And so that's where it starts. But then, of course, there's going to be some consideration for flexibility of the staffing overall, and that there may be shifting of the incoming staff, which I don't think that's going to be necessarily the best use. I think, again, hospital-based setting is going to be, especially GMH, is probably where they're going to be the most useful. But if either them or other staff members at GMH are going to be shifted over to SNU or to GRMC, whatever makes the most sense in terms of being the most efficient, taking care of the most amount of patients.
yeah, so Lillian said yesterday that 15 GDOE nurses were undergoing orientation yesterday to help fill the staff. But the other thing she said yesterday was that there have been staff at GMH that have been testing positive for COVID-19. And so, I mean,
Yes.
do you have any information on that? Is that something that the Physicians Advisory Group is keeping a close eye on in terms of how many of our healthcare workers, our frontliners in the healthcare industry are testing positive?
Yeah, and so I don't have the exact number with me, but it's something that we are continuously inquiring about, because we're talking about all staffs from all different departments and levels, and we're talking about physicians as well. And so that's a big concern, and so GMH is being stretched beyond what we initially had understood and appreciated, and that's really taking a toll. So the timing, is very, very important in terms of how these reinforcements are coming in. And again, just to reiterate that, the staffing that is being affected is they may be primarily employed at GMH, but they also moonlight at, or in other words, have a side hustle at GRMC,
Right.
and that affects this GRMC staffing as well.
So do you know, Doc, offhand, how many staff have been sidelined, not just for testing positive, but because when you get tested and you got to quarantine and you got to stand down for the 14 days? Because it kind of seems like it's a significant chunk. And that being said, how is that affecting the already stressed operations at the hospital?
I don't have an exact number on that right now, but it's something that we're very, we have a lot of intent to have that actual number known before tonight's PAG meeting.
How much of this shortage, though, is because healthcare workers are testing positive, or is it because we need more healthcare workers because there's more and more patients coming in? Or is it kind of like both?
I think it's about 50-50.
Yeah.
Honestly, I really do. I think it's 50-50 as much as one part of it by itself would have been an emergency situation, but then to have both is a double emergency, double jeopardy, if you.
Are there any plans to just change GMH to just be a 100% COVID patient hospital? Because when we spoke with Lillian, there's this constant exchanging of patients between GRMC and GMH. But is there just any sort of long-term plan where I guess GMH during this pandemic crisis will just be the hospital that handles COVID patients and then just move everybody that's non-COVID over to GRMC?
That decision is ultimately up to the administration of GMH. And, despite, many recommendations from the community, from other physicians, Dr. Ricardo Eusebio was just on, just speaking to the media yesterday about this. He had been contacting myself and Dr. Mike Cruz over the weekend because he shares the exact same concerns that we do. But again, as the physician advisory group, as the state surgeon cell, we recommend and we advise, but we don't decide, the policies and the actual action plan unless the governor gives us the explicit order to do so. And as right now, GMH, of course, is still very much run by its own internal leadership. And so, this is something, but as far as moving entire inpatient services, such as, OB and pediatrics, that's a whole different discussion than just, the back and forth between non-COVID patients being moved over to GRMC on a one-by-one basis to offload some of the pressure on GMH. But, the onus lays on GMH and their willingness to temporarily move their patients and the specialized staff that goes with that to GRMC, which will make, and I'm sure GRMC will make the space available because physically there's room there. But I'm sure they have their reasons, but we have yet to fully understand, how that outweighs the clear and present danger that exists for these special patients, and the risk of them acquiring a nosocomial infection, or in other words, a hospital acquired infection.
Has there been any hospital acquired infections?
Well, right now I know that Lillian says that they're looking and that they're studying that, but I know a lot of inferences can be made, about this from what we know and from what's reported from family members and as well as other staff about the conditions, especially of the ICU nurse that had passed away at GMH, and that there's a lot of information. I'm not saying anything that's new right now, and that she had tested negative multiple times prior to being admitted, and that she was admitted for non-COVID related medical conditions, but then had tested positive within the week that she had passed. And so that's quite a concern that we have. And in fact, it's I'm clearly understating the concern and that we have with that. And that, I know that they need the time to ensure that, infection control is an entire department. In a hospital. It's that important. It's something that's not new to a hospital in terms of what they have to fight every day. Being admitted to the hospital is never a benign event, even if it's for something as simple, a simple surgery that you stay overnight or what have you. It's never benign because there's always going to be that risk that exists of a nosocomial event,
Right.
or in other words, something that happens in the hospital, whether you have an infection or you fall and break your hip, along those lines. So there are departments dedicated to preventing these things, and so one of them is infection control, and they need the time to do their full investigation and their full root cause analysis so that they understand what exactly happened and what are the specific things they can do to prevent this from happening again. And part of it is understanding what the true risk is and what you can control and what you absolutely cannot control. And things that you cannot control are the things that you have to mitigate the most. And so that's the key part here. And I know they need the time. But to confirm whether or not there's a hospital-acquired infection, so the problem with that is that you will never know 100%,
Right.
no matter how much evidence that you have, especially in this case, because a scenario could be that, yes, a patient that was down the hall has COVID, and then a nurse took care of that patient and then end up coming and taking care of another patient and then brought that virus with them and infected that other patient. Yes, that's one plausible scenario. Another plausible scenario is that somebody from the community was visiting the patient who had COVID, and COVID is not something that shows up itself, and that's part of the problem with it. What makes it so virulent and so and such a nasty virus is that it hides, and it hides itself from temperature scanners. It hides itself from PCR tests sometimes. And then it pounces on you when you least expect it, and it transfers. And again, as I've said in the past, is that it's a virus that preys on our cultural values, and it takes advantage of it. And it's something that we can't completely exclude, that this is, it's definitely a nosocomial infection if you acquired it within the hospital, but as to the actual source, it's, we'll never know for sure. But I think either situation is just as plausible, whether or not it came from a different patient in the hospital or it came from a healthy looking person in the community that came into the hospital.
Right. Yeah. So we asked Lillian about it. I mean, she did say that, they're still investigating it, but I don't know about you, Brie. It kind of seemed to me like she was leaning more, and, I'm pretty sure she was because she's trying to protect her staff, but it's like she was leaning more towards it was somebody who visited the hospital as opposed to a staff who infected the patient, which you're right, Doc. I mean, we don't know, right? And then when the investigation is concluded, of course, we're going to question that. So here we are. If anything, I hope that
when you're having this many of the staff turning up positive,
right.
I think, I don't know numbers on specific in terms of, the odds of how, given that there's so much staff at GMH, what are the odds that some of them are going to become positive anyway, just from being community dwellers?
Right.
I think it's disproportionate. That's just my gut take on it. I don't know the exact numbers, but I think it's a high number compared to the rest of the community.
Well, we had Dr. Alm on last week, and he had said that there were 20 COVID positive cases at GMH since March.
That he's aware of.
That he's aware of. Yeah.
Yeah, there's more. I'm almost sure of it. There's more. And I learned of many more yesterday that turned up positive as well.
How many more?
I don't have the details, and I got it under, in a unconfirmed report, basically. So I want to be sure that I have that confirmed. But there were several, not like a balloon number, but just enough that, and in certain key staff that we were worried about. So staff again that worked at both hospitals. So we have to be sure and understand where they crossed over.
Wow.
Would this be like a cluster at GMH?
It's hard to say because there are a lot of staff that don't interact at all in GMH, just with different units. And so it's hard to say that.
But right now you don't know if what's happening at GMH would be considered this, what did you say, nosocomial hospital-acquired infections at GMH? Yeah. Is that what it's called, nosocomial?
Yes, nosocomial.
Nosocomial.
Yeah, like nosocomial.
Right.
And so the, I think right now the odds are that yes, it is a nosocomial infection, and it's something that you're probably not going to get much more data or or evidence that proves that it is, and most of the time we just take it as it is. A typical example is like if you have, I think you may have heard of it's known as MRSA.
Yeah.
MRSA is the superbug of Staph aureus
The Granu.
mensis. Yeah, and so that's a typical one that we're worried about in terms of it being a nosocomial infection within a hospital. So if somebody comes in without MRSA and there's other people with MRSA in the hospital with that infection, and if that other person ends up getting MRSA, then it's easy to presume that probably came from the hospital. And the thing is that you have bacteria and you have viruses. Now, viruses tend to be much more easier to spread in a lot of different ways, and are shown much easier in terms of especially with COVID. Whereas MRSA is a bacteria, and that's it's a different way of transmitting in that sense, and it's more of a contact, and so that's something that's different as an example. But influenza itself can be nosocomial. Other things, common cold can be nosocomial. Anything can be transmitted. So it really brings to light the importance of infection control.
Right.
And again, each hospital it's mandated to have its own infection control program in order for it to meet CMS requirements. And so it's very complex, and right now I can tell you that for the size of both GMH and GRMC, that there's a tremendous amount of resources that have to be put for a hospital that size, and it's not just one infection control nurse that's responsible, that it's a team that really needs to be part of it.
Just for clarification, you said that it's likely that were you talking about the nurse was a nosocomial infection, or are you talking about the healthcare workers at GMH?
So nosocomial being more in reference to inpatients. And so what we're talking about is, I'll be specific. I'm speaking about Marnette,
Okay.
and that in terms of Marnette and her passing, and that according to her son, that she was tested negative multiple times prior to her turning positive, and this is all while admitted in the hospital. And so Marnette had been admitted since early July, and she had been working up until then. And again, she's somebody who worked full-time at GMH and worked part-time at GRMC. And she's somebody that I remember a few years ago when she first started moonlighting at GRMC, how excited I was. I gave her a big hug because I was so excited that we had somebody as senior as her coming to GRMC to help with our very, very junior nurses that we had, especially at the time, and that she was going to really participate in the training of them and as a housing nurse supervisor. But she still, and the more we had these crossovers, the better that the hospitals had an understanding of each other. And so I always encourage, people moonlighting from one hospital to the other, including the other way, GRMC full-time and then moonlighting at GMH. And so she was really part of fostering that. But yeah, so going back to the original question, that yes, it was specifically that we have every reason to suspect that her infection was the nosocomial infection.
If the family is planning any legal action or anything, if we're already at this determination that she caught COVID in the hospital, whether or not it was from a staff or a visitor?
Yeah, I've had zero contact with the family. I have no idea what their intentions are. I would just say this is that if anybody understood nosocomial infections very well, it was Marnette. And she understood that risk always exists, no matter how much precautions you take. And so if, and God bless her soul, but if somebody was going to be understanding of when to be forgiving of it, it would be Marnette. And in this situation, in terms of how I knew her as a colleague. And so I'm not trying to take that away. I'm not trying to discourage the family from doing what they think is right. But I'm just trying to express what be my impression of her. And maybe I'm going too far in saying that. And so, but in the end, I just hope that whatever actions are, that the actual intent is to improve the processes that we take here on Guam, and that we always strive to do better, and that instead of bringing up, and that's the problem that we have the most, I think, in it's human nature, and unfortunately it's magnified within the government of Guam system, that when there's a time and a need to be self-critical, usually those are not taking advantage of at the greatest in terms of of improving oneself, and then using that as fuel as a learning experience. And so we really hope that this changes that, and that we actually really take advantage of it. And the other thing I'll say is that if it wasn't clear, the tone I've been taking here is that we've had months to prepare for this wave. Months. We've had a lull, and we have not done enough to prepare for this. And I think that that's very clear. And it's I don't know if it's because because it was more of a reprieve from the first wave that we had, and then trying to get caught up with a lot of things. But the key part here is that we had to sharpen the saw, and that we had to really look at what we needed to do to improve. And that's part of that was ensuring that SNU was brought up line and was ready to go for the next spike, because we made it very clear that we had no idea when it would come, but when it did, it was going to hit us real hard and very quickly. And sure enough, it did. And it even, with everything that with all the data that we look at, it even, hit us with a relative surprise too. I think we moved to P-Core 1 in a very timely fashion. I think that was very good in hindsight. We were nervous about doing it, thinking it may have been too much at the time, but we're very glad we did so. I hope that everyone can put aside, cannot connect the review of our processes and the critique of it, and make it more about the system and not about themselves. And that's what happens, I think, with a lot of leaders, is that they take this as a criticism of themselves, or even a failure of themselves, when nobody cares about that part. We care about doing the right thing and getting better. And we try and I hope that we embrace the philosophy that 25% of our efforts have to be about improving. And if you're doing 100% of your efforts about covering your butt and backtracking and doing all that, then you're just making things worse. But if we do 75% of our work that's about the day-to-day and tomorrow's work, but then 25% about next week and 1 month from now and 1 year from now's improvement, then we're on better ground. And I think that we need that shift in mentality. And when other physicians are calling out other physicians in a extremely unprofessional way that has no way to improve that type of mindset, then we are going backwards in a major way. And I think you know what I'm referring to.
Doc, well, let me just ask you this, right? So you pretty much just threw the government under the bus and saying we didn't plan for this, which we all know, obviously. When we were getting the zeros and the ones, we weren't planning, we were partying. We're like, we beat COVID. We're the first place in the world to beat COVID. So
I think though we had those plans, because I remember the press conference, we had the tents.
Right.
We're going to set this up at EOG.
Yeah.
We went through this whole exercise in these press conferences, like, this is what we're going to do,
Yeah.
And then we just never did anything.
Yeah, and that's what I'm saying, Doc, is if you're saying the
and
government...
we had all these deaths, and it's just
exactly
so
what saying.
frustrating
A
and
lot of it was
sad.
theoretical. Yeah, so a lot of it was theoretical. We put the ideas there. We put basically the blueprints for it there. And in terms of actually starting to put a foundation for it, at the minimum a foundation for it, I think that's where we didn't do a good enough job. Now, part of that, part of this process is using the term like throwing somebody under the bus. This is not me throwing the government under the bus. This is me talking about what all of our responsibilities are, and if anything, I'm throwing myself under the bus.
Yeah, that's what I was going to say, Doc. So we're talking about the planning, and then you're part of the group that's supposed to advise the governor on the planning. So, yeah, I mean, I'm just saying, if we didn't plan, then
I
that's
have
partly
no
your...
reservations to speak about the shortcomings that I'm a part of as well. I hope it's clear that I'm talking about myself as well, and the group that I work with in terms of the state surgeon cell and the physician advisory group. That's the tone that I'm speaking on, and that we all have to do better in terms of following through, and I think that's part of it. And at the same time, that's what the rest of the community has to do, is follow through with your part and your role. Everyone has a role in all this. So that's where, basically what I'm rolling here. And so, unfortunately, this has, most of this discussion has taken its role with in terms of the conflict between Dr. Akimoto and Dr. Manglona, and that's really one of the worst forms for this conversation to happen in terms of what's going on there. But at the same time, I'm just going to say this right now is that Dr. Akimoto is extremely critical of the government of Guam, and I think and has not no criticism for the rest of the community, but we know it goes both ways and it's two sides of a coin. But at the same time, what makes him really the great motivator of government performance and community behavior? That's one of the other things that why does he go down this line, and what makes him think that the things that he says and the methods that he uses is really going to be the answer to change in the government. And maybe the things that I'm saying right now is not that as well, but definitely the lines of language that he used and the approach that he's taken is completely in the wrong direction, and I want to be very clear about that.
I wanted to follow up on the nosocomial infection and the hospital-acquired infection. Now that you've kind of come forward and believe that there is this hospital-acquired infection with Nurse Agavao, and the fact that we've seen more healthcare workers, to include doctors and nurses at GMH, that have tested positive at the hospital. And I didn't see Dr. Eusebio's interview anywhere else. But to me, it would just seem that if we're having hospital-acquired infections at GMH, that we would move non-COVID patients out of there and into I guess GRMC, because it's the non-COVID hospital.
Yeah.
And so are we going to hear serious discussions about this
serious,
potential?
because we heard this back
and follow through.
Yeah, March and April, it was like, God, Bree, it was like every day they were going to move the women and children to GRMC.
Yeah.
Every day for like 2 months.
And
it never
according
happened.
to Lillian, they did move some people because there were talks about moving patients to the Guam Surgery Center to help handle the overflow. And then it became, well, instead what we're going to do is we're going to move staff from the Guam Surgery Center over to GRMC and then move the patients, the non-COVID patients, to GRMC.
Yeah. So let me be very clear that there are movements just about every day, multiple times a day of patients, non-COVID patients from GMH to GRMC. But this is basically a la carte. It's individual one-by-one kind of. There's constant communication. We have a forum where we discuss this amongst the hospital clinical leaders between both hospitals. We look at saying, hey, we have this many beds available. What can you give us? And so that process, so then GMH will look at and say, okay, we can move these tele patients over, but at the same time, the patient has to consent, or their surrogate has to consent to the move. And so there's a lot of moving wheels, and it's not just simple to just say, okay, call the ambulance, we'll bring them over. That there's a lot of coordination in order to do it safely. But that process is happening every day. So GMH has done an excellent job of doing that. I want to be very clear on that they've been very good, and that they don't just hold on to the patients, for whatever reasons that they know the importance of decompressing. But in terms of moving actual units like the OB, labor and delivery, or pediatrics, that's a whole different discussion, and I think that's an important question that needs to be continually asked to both Lillian and to Dr. Annie Bardalio, and that that they are the two that ultimately make that decision in that process. And just remember that if you move OB, you have to move peds as well, because
Right.
The end result of OB is peds, and so so you have to have both there. And right now, the maternal child health is not an inpatient unit that exists at GRMC. And so, but I understand the concerns that there are some staff that go between, but that's part of the problem, is that there's staff that go between. If you have labor and delivery staff that's helping out with COVID patients, then you're just introducing a vector. And so we have to accept that and understand that in a better way. And even if the number of hospitalizations start peaking and start going down, it's still a lot of patients. There's still a lot of COVID patients in the hospital, and it's going to take a while before they start really dropping down to single digits.
I wanted, if you could just stress the importance, because we see the numbers that are coming out, and I just don't want people to think that, because we only had 48 yesterday, that we're doing better. if you could just stress, and just tell the story behind the numbers, because
Right.
to me, it doesn't mean that, oh, we're on this great, track record right now.
Right. Because if you look at the test positivity rate, I mean, it was higher than 10% last night because we had 48 positives and 400
let me
something tests.
I'll just tell you what the numbers are right now. So at GMH, right, as of last night, I haven't had this morning census report yet. It should be getting in the next few minutes. But as of last night, there were 39 admitted patients at GMH that are COVID positive. And at GRMC, there are 3, one of them being ICU. So that's a concern. And then thankfully at Naval Hospital, they've gone down. There are about 3 patients down from 6. But one of those are also ICU as an ICU patient. So you add that all together, you're talking about 45 patients that is admitted into a hospital setting at this point right now. And so those numbers are still alarming.
You said GRMC, so GRMC now is taking COVID patients, or they just can't move them over to GMH because there's no space?
We can't move them, and so that's the key part. There's that we can't move them, and that we've been trying to move them, and then as soon as we move one, then another one comes in through the emergency room, and so that's typically been the case. And I want to clarify one thing, because this was actually asked of me at the last press conference, and I don't think I digested the question well enough before I answered. But there was a question about why we're seeing if you look at the JIC reports, why are there so many positives at GRMC that we're seeing? And it's so, yes, part of it is that they are being turning up positive within the emergency department, but it's not that there's all these inpatients that are turning positive. And a lot of those positives are actually from the outpatient-based testing that's being done. That's either from the clinics or from other entities that have businesses that have contracted with GRMC to do their own testing. So that's through the drive-through that's there. So just it's really more of the outpatient type of testing that drives those high numbers at GRMC. So not the inpatient side, but still having 3 admitted patients at GMH that are COVID positive is 3 too many right now in terms. And so that we've been forced to make a lot of changes at GRMC to accommodate this basically a steady COVID unit. That's
so Doc, are you? How close are you guys to starting to opening your own COVID ward if you've already got the 3 in the ICU? I mean, I'm assuming they're compartmentalized in that intensive care unit, right?
Yes, I know they're compartmentalized in the emergency department.
Okay.
But
And
if
so that's
I was going to say,
Sorry?
but if that SNU facility was open ever since, we wouldn't be having such a serious backlog or
well, the
backlog we have
hope
right
was
now?
that it was going to be a way to offload the lesser the patients with lesser acuity at GMH to go to a place like SNU, and that would free up more room at GMH, and then that would have opened up the flow for patients from GRMC to GMH, and maybe in some cases some patients from GRMC directly to SNU. But really that was the bottleneck is the disposition from GMH, and so that's where the isopac facility comes into play. That's where SNU comes into play, and so that's that's something that's finally being we're seeing the light for that bottleneck in terms of opening.
Yeah. And according to Lillian yesterday, she said she's been in talks with FEMA, Bryant Trang, and they're 95%. She's 95% done with the plan to submit and hopefully get approval from FEMA to open up the SIF to also take in, provide ICU level of care. But then it goes back to what you were saying earlier, and what we have been talking about is, where are we going to get the staff?
Yeah. And I think ultimately, everyone's preference is to only do ICU level care within a hospital, and so really that's it. So in a different scenario, we would consider, but doing the full services at SNU. But
So
to be
Doc,
able to do care is a whole
SNU,
different.
that would be, as it is now, we only would have the capacity to take care of like middle, and for lack of a better term, like kind of middle of the road COVID patients, not the ICU level ones. That's pretty much what you're saying.
My understanding is that and lower. Yeah.
Right. Okay. So it's just basically like a beefed up isolation facility.
Yeah.
Okay.
that would
And
still
still, in a
need.
way, also so that, so that
Still need staff.
it doesn't take away from public health's focus as well.
Right. I got last question, Doc, because we gotta really move on with these infections that we're seeing with the nurses and the staff. Do we need to go back and revisit our protocols as far as like the PPEs and stuff? Do you think that there could be
Yeah.
something that we're missing? Because I've seen national stories where, and you just got to wonder.
So I mentioned earlier doing a root cause analysis, RCA. And so that's exactly what that is that you go down into the nitty gritty and you dissect every part that of what you're doing and potential breaks and leaks into that. And if there's potential Swiss cheese holes that are lining up in a way so that you plug them up, and so that even if they did line up, that nothing will fall through. And so that's part of the process, and we have to have there's both some patience and urgency with that, and that as soon as things are learned through it, that we start making changes at the same time, but still let the allow the process to fully develop.
Sorry, Doc, I did have one more question for you. I know that the Physicians Advisory Group, they talk about quarantine protocols when you need to, make it stricter, or maybe even provide like home quarantine. And, the last we had heard like from Dr. Hoa Nguyen is that it's mandatory 14-day quarantine in a government quarantine facility. No ifs, ands, or buts about it, right? That's where we are.
Yeah.
But yet yesterday, and I don't know if this was something that the Physicians Advisory Group recommended for implementation, we saw these buses, and Chris actually covered it,
Yeah.
these buses of people from quarantine being allowed to attend funerals or a viewing over at the San Augustine funeral home.
Right.
So is this something, a new policy that you guys are going to be rolling out? Because we were told this was a trial run.
Yeah, it's a pilot run, and it's something that we understanding that this virus preys on our cultural values, and that this is very much a big part of our cultural values and how we mourn our those who have passed, and that we have to figure out a way to do it safely, and that we have to modify our cultural values so that we still maintain the core of it, but that we do it in a safe manner. And so by having eyes on this and actually doing it in a escorted fashion, so to speak, I think we learn a lot from it. And I think that that's something that we want to do. And so it doesn't break away because they're still under quarantine. They return to quarantine. But it's one of the things that if it's done in a safe fashion, that has to be the path that we're going to live, because we're going to have to figure out a way to live with this virus for a long time.
Right.
And that we're looking at months and months before we have any true actual answer for this, and it may come in the form of vaccine, but even then that vaccine has to be proven.
Okay. Yeah. No, I just wanted to say I was on the scene and there were like nobody from public health there. It was cops trying to mitigate mingling of quarantine people, and I just feel like there's a lot of room for error. And I understand that's what the test run's about. But anyway, so we got Jess and Al from public health.
Feedback to hear,
Right.
that we need to hear that specifically.
Right. Thanks, Doc.
Well, he was there.
Yeah, I was. I was on the scene.
Were you doing
In Zori.
practicing?
I was wearing my
Zori?
mask.
He
Yeah, of
went
course.
to pick up lunch, and I was like, "What's taking this fool so long?"
I was like, I got a tip, bro.
Okay.
Yeah, and I mean,
Right.
dog, it was crazy when I rolled in there. That bus, it was like people in the apartments around were just like, "Oh my god, what is going on?" Is that a? Because everybody knows there ain't no school right now. You see the yellow bus, that's coming from the quarantine.
Yeah.
Bag. Give me 50 feet. Thanks, Doc. We got to run.
Take care.
Okay.
Have a good meeting
Stay safe,
tonight.
everyone.
Okay.
Yeah. Okay.
Okay, see you. Mary, Dr. Felix Cabrera, the spokesperson for the Physicians Advisory Group there. They advise the governor. 727. I got to take a
Wow,
short
that was
break.
informative.
That was, yeah.
That was really informative.
I know. I was like, okay, every time I looked over, you're like, we got a little system in here. If you see any of us going like that, and that means I got a question. Nonverbal cues. 728, again, it's the link.